Okay, good morning. Good morning. We'll go ahead and get started. It looks like the trickle from the hallway is starting to die down, so we'll just get going with the lecture. I'll introduce myself. My name's Chris Ghaemmaghami. I had to check the slide just to make sure. I'm the Chief Medical Officer of the health system and the Senior Associate Dean for Clinical Affairs in the School of Medicine. And you may say, well, that's a lot of words. What does that mean? Basically, I am the physician operational leader for the hospital and the clinics in the UVA Medical Center, so in the health system, kind of wherever we go. And then I work in the dean's office with Dean Wilkes as we manage clinical operations with each of the clinical departments. So I'm an emergency physician by trade and work most Fridays in the ED, some shift or another. Still like to work overnights to kind of see what really happens when all the parents are gone, and it's kind of fun. So I know there's some EM residents here, and I see some neurosurgeons. Who else do we have? What residencies are represented here today? Anesthesia. So that's probably a big group, right? So, okay. Anybody else? Ophthalmology. Okay. Okay, great. All right, Red Onc. Okay. So a good collection of some hospital-based specialists as well as procedural folks. So what we want to do today is just sort of really talk about how's a hospital work and how does this fit in terms of the missions of an academic medical center, and kind of go through a couple of topics. So first of all, you may be curious about what are the entities of the health system. And then we do want to talk about sort of this shift that you guys are witnessing as we hear news every day. There's policy changes every day, and just sort of the economic realities of the future. How we're shifting from a volume-based or fee-for-service type environment to a value-based environment. That's going to affect everybody in this room. And then we just want to talk a little bit about patient flow through the hospital and kind of give some perspective to you in your area in terms of how it affects the whole. So first, you just have to talk about the basic goals of the academic medical centers: clinical care, education, research. These are kind of classic tripartite mission. We try hard to balance all of those things. Really, my job is to focus, this is a very weird pointer, on the clinical care aspects of things, but at the same time, I have to support the environment for education and research. So it doesn't do everybody the greater good if we set up sort of just a clinical assembly line where we're just putting people through and delivering clinical care. We need to make sure that there's the right educational milieu for you guys and to be able to support research. So examples of that, do you have time in clinic or space in the hospital for patients on clinical trials? So you need to sort of plan around those kinds of things. So hopefully at some point in the last several months, or for many of you who have been here for multiple years, you've seen this slide, hopefully in some context or another. And this is the 6 health system goals. We take this pretty seriously. Our operational goals for the year are based on these things. You've heard a lot about becoming the safest place to receive care, and I can tell you that for our patients over the last 3-4 years, we actually have raised the bar quite a bit in terms of the safety in the environment. The number of unanticipated mortalities is significantly down. The number of hospital-acquired conditions is down, and we see better outcomes in our patients, and you see that reflected somewhat in the rankings and things like that. But you can drill down to a pretty deep level and see that that's actually a reality. To be the healthiest work environment, that is a very tough one. That has to do with everything from the smallest item of a personal injury You know, and you guys have been educated a lot on needle sticks and exposures, but this safety goes all the way up, or this healthiest work environment really goes all the way up to you know, employee wellness, physician burnout, these kinds of things. So really that's, again, a very high priority, but a very tough one to deal with. Providing highest level of clinical care, that's something that UVA has generally prided itself in terms of things that we do within the Commonwealth. You know, and it's gotten to the point where we actually look at programs and we say, you know, do we deliver the highest possible level of care that you can do in Virginia for any of the programs? And if the answer is no, we say, well, how are we going to fix that? Or we're going to get out of that business. So there's no in between. So, you know, that's a very serious proposition. And then you can see there's the research goal, the training goal, and then this idea of stewardship or value-driven and efficient use of resources. So that's kind of the context, but okay, it's words on a slide. How do you actually turn that into daily operations? And we talk about operations versus you know, sort of the other missions. You're really talking about, you know, how do you deliver the care in a very concrete way? What do the teams look like? What's the structure around that? And how do you support those? So what is the health system? So you hear a lot of words sort of used interchangeably at times, and it can get a little confusing. But the health system is basically this. So there's the medical center, which is not the health system. Okay, the medical center is the hospitals, the clinics, outpatient surgery center. So to some degree, it's a lot of the buildings, but it's the buildings where clinical care happens. The transitional care hospital is part of the health system. I don't know if any of you have been out there. Kind of an interesting place. It's what's called a long-term acute care facility. So this is people who have acute care needs, not just nursing home needs, who need to be in the hospital for an average length of stay of 40 days. And so then they have to be able to participate in rehab needs or in rehab and have significant intensity of illness. So other entities of the health system, of course, include the School of Medicine, the Physicians Group, and the Health Sciences Library. And we have at least one formal partnership in clinical care, and that's with this Novant UVA health system. And so for those of you who are confused by this, so there are 3 hospitals sort of in central northern Virginia, Culpeper, Manassas, and Haymarket, where we have a joint operating company with a hospital group out of North Carolina, Novant Health, where we have a 60-40 ownership relationship with those 3 hospitals. And so we run those hospitals. Now, I don't run those hospitals, but we have a joint board that does. And so we actually are the minority owners in that. We control 40% of that, and Novant controls 60%. So, you know, this was a big deal. They got UVA in their name, which has value, and, you know, that was a very interesting arrangement. So that continues on, and we are working to develop clinical services in those areas. So Culpeper, of course, is the closest one to us, and I think it's our number 2 referring partner. So if you look at all the transfers that come in to UVA Medical Center, Augusta Health is number 1, and I think Culpeper is number 2. So we do draw a fair number of patients from that sort of Route 29 corridor to the north of us. So even though this is a health system, all of these are actually, not all, most of those are different financial entities. So the medical center is financially distinct in a corporate sense from the physicians group, and the physicians group is actually distinct from the school. So there are really 3 major entities. The library is its own thing, but that's sort of a small piece of this. So it creates some challenges in terms of alignment and trying to get everybody kind of moving in the same direction. What might be good for the doctors may not be good for the hospital. what might be good for the school might not necessarily be good for the clinical enterprise. And so you ended up in these negotiations constantly. That's what I spent a lot of my time doing, is trying to get everybody moving in the same direction so that we can take care of our patients and we can conduct these other missions. So it sounds like, boy, that's really fuzzy. You know, how does that work? But basically it comes down to getting people at the table and trying to decide how to generate consensus and follow a plan. So I don't want to just stand up here and talk the whole time. I do have, you know, a number of slides, but this is probably a good place to ask if there's a question about this, because this confuses a lot of people. Okay, don't care. Okay, so who do you guys work for? On this list, who do you work for? Yeah, you work for the hospital, actually. So you don't work for the medical school, which is sort of a fascinating kind of thing. I always thought that was kind of neat, you know, because you're learners, but you don't really work for the school. You don't work for the physicians group, right? So you actually are medical center employees. So it's sort of a different category, and everybody struggles with that a little bit. Okay, so what does this mean, shift from volume to value? So historically, we've been in a fee-for-service environment, very simple model. The doctors or the hospital deliver some care, they send a bill to whoever the payer is, and you get paid. All right, you don't get paid everything you bill, right? But you'll get paid something. And so what that encourages is production, all right? Just more activity. What it doesn't actually encourage is outcomes or health. And so this has been a widely recognized issue. You've probably had lots of speakers come and talk to you in various forums about that. And so now that we have grown production in this country to you know, almost a maximal extent, you know, we have to really look at this and say, for all the money that's being spent in this country on healthcare, are we getting what we should get? And what are better ways to do it? And so, you know, as you can see on this slide, success is measured by the ability to maintain just volume of inpatient admissions, volumes of surgeries, volumes of procedures, clinic visits, things like that. So does anybody, just off the top of your head, you know, any health policy kind of wonks here who know what percentage of the GDP now is healthcare expenditure in the United States economy? Somebody. I'm sorry. Yeah, it's 18%. And those data are old. So it's a sixth of the economy. And so it's basically the single largest business as a sector. And that's not sustainable. It's just frankly not sustainable. And there's a big demographic wave. Everybody's heard about it your whole lives of, you know, the baby boomers are all going to get on Medicare, and it's going to be a huge, huge expenditure. So if you look at healthcare spending in the US right now, between Medicare and Medicaid, it's about 50% of the federal budget. So you know, it's something like 10,000 baby boomers are joining Medicare. I think it's every week, something like that. And so the number of beneficiaries is going to be so high that, you know, basically the country's going to have to make a decision of do we just kind of keep the program the same and incrementally, proportionally increase that expenditure at the cost of other things in society, or do we figure out ways to not spend as much money? So this is a fairly early, relatively early lecture, and you guys have had only 1 or 2 cups of coffee so far, so you're sort of like, oh man, what is this guy talking about? This is a downer. Yeah, it is kind of a downer, but really it does beg the question of, well, what's next, you know, and how is this going to work in the future? So there are tremendous pressures on the system right now. And we have to figure out better ways to actually reduce waste in the system, reduce errors in medical care, and really just focus on things that actually help people. We do a lot of tests. Tertiary medical centers are sort of very guilty of just doing a lot of tests because we have access. So, we have access to tests, so we have increased utilization, but that doesn't necessarily translate into any kind of different outcome. All right, so we talked about value. So how is value defined? This is the classic equation for, value is quality over cost. So for whatever quality outcome you get, how much does it cost to deliver that? So if you have a patient with pneumonia and your quality outcome is that they survive, how much did it cost for us to deliver the care to enable that outcome? So if you are very inefficient, it may cost you, on average, $50,000 per case of pneumonia. But if you're really efficient, maybe it costs $10,000 per case of pneumonia. And so this is really where we are looking. In the past, it's all just been about revenue and expense and volume. And it didn't really matter to the system what the outcome was. This is just another version of this that sort of breaks out what makes up quality. So most people would talk clearly about outcomes. We've talked about safety and actually now service. So what is that interpersonal service relationship? And in other industries other than healthcare, customer service is sort of a big feature. Here, it's a smaller factor, but something that is very important to the patients. So I'm not going to be one of those people who sort of, teaches the mantra that, if your patients are happy, then everything must be good. That's not true. But there is benefit of the patients having a good experience in the system. All right. So you hear quality and safety sort of being interchangeably used in a lot of contexts. And I just like to frame it very simply. So when you talk about quality and outcomes, it's making sure good things happen, all right? Safety is really just making sure bad things don't happen. Kind of a subtle difference, but if you can just walk around with that thought, it actually clarifies what is really the difference between safety and quality quite a bit. When we talk about safety, we review things like mortalities every day, well, Monday through Friday. We review every mortality in the medical center every day at 10 o'clock in the library. You probably walked by there at some point and you said, what's that huge crowd of people doing in the library? So one of the main things that we're doing is we're looking at all the adverse outcomes, including safety outcomes. So invite you to join, squeeze in and hear. It's kind of interesting, what gets talked about. But basically, we're looking at things that if you are a patient, what is it that you basically don't want to have happen to you? Okay, so you don't want to get hurt by coming to the hospital. You don't want to get an infection by coming to the hospital. You don't want somebody to do the wrong procedure on you when you come to the hospital. Those are all safety outcomes. Quality is, again, things like, okay, I have cancer, I got treated, I'm going to live X amount of time more, that kind of thing. So I know it sounds really fundamental, but you would be surprised at how many people get confused by what is the difference between these two concepts. All right, so how do you start changing from volume to value? So we already talked about this a little bit. You focus on your outcomes and you have to just remove any kind of waste in the system. And then ultimately you have to figure out more efficient ways to do the same thing and get the same or better outcomes. So there's a school of thought that there's enough waste in the system right now that if we reduced all the waste from things like medical errors and medical complications or over-testing, that would be enough. That we would be able to, kind of get through this demographic surge that we're all looking at, and it'll be okay. We'll still spend 1/6 of our economy on healthcare, but we'll make it. And then there's another school of thought that says, you're gonna have to do all of that. Hopefully you're gonna do it in a smart fashion so that people don't get hurt. But ultimately, Americans are big healthcare consumers, and there's probably just gonna need to be less of everything. So we'll see. We'll see what happens. This is, we had election day yesterday, right? So what was not really on display as much in this past election yesterday as say, a year or so ago was there's a pretty big philosophical rift on what's the role of government in that challenge. And, hopefully I'll still be working you guys definitely will be working, we'll be able to see which way this is going to go in terms of, does that curve actually, in terms of expenditures, continue to go up, or does it in any way flatten out? And by flattening out, it has to mean that it's fewer dollars per individual because there's more individuals in the system who need healthcare. So it'll be interesting to see what happens. Yeah.
When you talk about like the competing goals and everything between value and like the optimum efficiency, the academic part of things, that's something that you try to quantify in terms of like it's acceptable for us to maybe run things slightly less efficiently compared to a non-academic institution because we're teaching and you hear all the time like, well, this is mostly like an academic pursuit, or the resident needs to learn this procedure that might be a little longer and more expensive, but it's for learning. Is that something that you guys actually put like a dollar figure on, or is it just kind of an
So you're talking about operational metrics on this, and so there are some that we actually use. So first thing is you have to have the right peer comparisons, right? So we're not going to compare our system and costs and outcomes to, say, Sentara, Martha Jefferson, because they don't basically have the other missions. So we make sure that we compare to other academic medical centers. You can see it's black and white. The cost at an academic medical center is an increment higher than at a non-academic medical center. And when you start really drilling down into what we would call operational metrics, things like length of stay, test utilization per case, drug costs we actually do okay with, but things that related to time, academic versus a community hospital look much different. They really do look much different. Now, it's not that the community hospitals are perfect, and they certainly have their own weaknesses. Because remember how I talked about all the different entities, how the school is here and the doctors are here and the hospital's here. That's actually even a little worse in a community hospital unless they have a closed medical staff of employed physicians, because they'll have 100 different doctors in 20 different groups, and so that's not something that is easy to manage. So to answer your question, there's a clear recognition that it's different. We do know it's more expensive to have a academic medical center and support all the missions, and the efficiencies are usually, you're lucky if you break even with efficiencies versus higher efficiency places, but usually there's some inefficiency that gets added in because of things that we all need, like teaching. Yeah.
How much pressure do accreditation bodies like JCO and things like that feel this pressure? Because it seems like, from our end, they add a lot of red tape to things that doesn't necessarily seem evidence-based, at least to us.
Mm-hmm.
And, sort of one more step, one more.
Yeah.
Feel this pressure to decrease waste?
So there are a lot of different players in healthcare, right? So you talked about the Joint Commission for hospital accreditation, and I would say from what I've seen from them, they have only scratched the surface on things like efficiency and utilization. They are much more oriented towards, do you have policies and do you have process, that are best practices. So just to clarify, so everybody comes at this discussion from a different starting point. So just to level set a little bit. So what is the Joint Commission and who cares? So is the Joint Commission the government? No. So Joint Commission for Healthcare Accreditation is actually a private corporation. And hospitals use the Joint Commission to establish accreditation with CMS. So CMS is Center for Medicare and Medicaid Services. They're the payer for Medicare, all right? So there's basically no hospital in the United States that doesn't participate in the Medicare program. Okay, so here, roughly a little less than 30% of our patients are Medicare patients. Okay, so if we couldn't treat Medicare patients, we would go bankrupt tomorrow. Okay, so we have to be able to do that. So CMS historically had gone to Joint Commission to be basically the inspectors. Okay, so they would go through and they would, do a survey. We're actually up for a survey within the next 6 months. We're in the window right now. They could actually show up tomorrow. They don't tell you when they're going to come, and but they'll inspect things and say, okay, yes, we give them a stamp of approval. We are deemed an entity that can bill for Medicare patients. Okay. So they are really more focused on remember that quality versus safety. They're focused quite a bit on safety these days and quality, but not efficiencies. So the tendency, the big criticism for things like Joint Commission is, they'll hear a new idea, they'll see a best practice, and that will get put into the rules, and they'll just add it on. So it's been this. It's sort of like the tax code, It should probably be a 20-page document, and it's grown and grown and grown and grown, right? And so it's just adding on, adding on, adding on. So I would say no, Joint Commission has not embraced really any kind of value-based modeling. But that's not really their role. Who has decided primarily to take that role is the payers. So Medicare, CMS, Medicaid, and then the big payers like Anthem, will put in, quality goals and metrics into their reimbursement structure, and that's the way you're sort of getting at that. How you solve that problem is now at the system level, the health system level. So sorry, it's a long answer. So here's just the interesting historical trivia about Joint Commission. So pretty much all the hospitals hate Joint Commission, right? They're like, oh, the Joint Commission's coming, and they're so awful. So who started Joint Commission? The hospitals. Okay, so actually the hospitals all came together. That's why it's a joint commission, as it was all the systems came together and developed the guidelines for themselves, and then the thing mutated and took over. Okay, so it's just most people again equate Joint Commission with a government entity, and it's actually a privately held corporation. So the good news is there's actually a Norwegian company called DNV that is a competitor of Joint Commission, and they accredit around the world, and CMS about 10 years ago allowed them to be a deeming body, and they're actually much more rational. They're like this very Scandinavian kind of like, more of a lean approach. Somebody had a question back here.
Yeah. So you mentioned how we're changing our payment model. Where's the hospital more?
Mostly, so you have to look at who pays for healthcare, in the U.S. And I would say that the tendency has been that whatever Medicare does, the third party or commercial payers emulate in some way. Now, been in this discussion for 15, 20 years, so now you're seeing iterations on things that were started a long time ago. So I would say that all of the commercial, or not all of the big commercial payers and Medicare now have defined some of these value-based models. It's a swinging pendulum, and there are different sort of stops on the swing. And so if you go back a long time into where there were true HMOs, where there was really managed care, that was a system basically of capitation. Okay, so you have a certain number of beneficiaries. The payer is going to pay the system who's delivering that care a certain amount of money per year or per month, and you just do it. Okay, so whatever the patients need, you do within some guidelines of things you're required to do, right? So that was one extreme example. Patients didn't really like that, and it got away from that. Now it's all these incentive programs. And so the way CMS, or the way Medicare has set these quality programs into play now is sort of interesting. So what they'll do is they'll say, we have this program that we're going to launch over 10 years. And the first few years, because we think there are some good things you should do, if you do the things we want you to do, we'll give you a bonus. We'll give you an incentive. So good use of this is electronic medical records. Okay? So why does everybody have an electronic medical record? Well, because the physician groups and the hospitals were all incentivized pretty strongly to get on board. But it wasn't just the incentives, because if you look at the 10-year plan, after the first year, the incentive might have been like, whatever you bill, we'll give you 3% more to do that, which is a big number. And then the next year after that, it's 2%. And the next year after that, it's 1%. And then after that, it's 0. Well, guess what happens in years 5, 6, and 7? You actually get penalties if you're not doing, what CMS wants you to do. So that's the pattern you see, and that's the policy decision making that you're talking about. So a lot of that comes directly from CMS. I mean, there's actually a guy. There's like one guy who's in charge of this. You should email him. His name's Patrick Conway. And he has set up all these like bundled payment models, and you've heard the acronym MACRA, which affects the physician reimbursements in terms of all these models. And they're just extremely complex and hard to achieve. So to answer your question, Patrick Conway, he's the guy who is setting the policy for this country right now. Now he has a team, but surprisingly, so he's the deputy director of CMS for innovation. You've probably heard of the CMMI, the Center for Medicare and Medicaid Innovations, and they have grants and things like that they send out development. They let people try and develop novel ways to do things. So he's at the top of this organization, but basically he has like 8 people who work for him. So 9 people are setting the whole reimbursement structure and strategy for Medicare. So basically the third-party payers just copy whatever is going to go on there, with the exceptions of big integrated systems like Kaiser. So Kaiser is an insurance company, okay? But they're an insurance company that owns hospitals and owns physician practices. So they're completely vertically integrated. So they just decide how much it costs for them to deliver care, and they sell a product to people directly. So that has nothing to do with Medicare, okay? That's just private insurance model. So you hear, so it's a really very, very different model. We sort of have one of those sort of growing in our backyard. So people don't really recognize this generally, but Sentara is a Virginia-based hospital system, mostly community hospitals. They have about 14 hospitals, and of course, they bought Martha Jefferson a few years ago. They bought Rockingham Memorial a couple of years ago. But basically, the Sentara Corporation has an insurance product called Optima. And so you can go out and buy Optima insurance, and basically they try and funnel you into the Sentara system. So they own the hospitals and now own increasingly larger numbers of physician practices. So they're trying to do sort of a Kaiser-ish model out of this. So basically, Sentara is really an insurance company. It's not a hospital company. Anyway, so within those systems, the administrators within those systems decide how they're going to incentivize the activities within those 14 hospitals and within those physician groups. So sort of an interesting model. So if you ever decide, to get a job in one of those systems, you understand, kind of what's the point? The point is to deliver care for those patients, but it's through an insurance product. Anyway, it's a sort of novelty. All right, I think I'm on slide 10, so I should probably move on. Okay, so what's happening with CMS? This is a good slide to talk about what we're seeing with both CMS and then basically some of these insurance products that are out there right now. The trend right now in terms of one concept in terms of how you reduce cost and therefore increase value is you put more risk on the patients and the providers. So when I say providers, it means 2 things. It means us, physicians and other LIPs, but also hospitals and clinics are people who deliver the service are considered providers in that language. So a hospital is a provider. And so basically, what happens is you'll buy some form of insurance or something, and these are the high copay, high deductible insurance models, so that before people access healthcare, they're going to think twice because it's going to cost them money directly out of their pockets. So that's been one strategy. The other strategy is that the system or the provider, meaning the hospital and the medical practices, take on risk. So that's much more like that Kaiser model, where you say, okay, we're going to take a population and we're going to take care of them. In these models, these accountable care models, you actually say, okay, this is how much we think it's going to cost. If we save money versus what we think it costs, which usually people will say, what was the 3-year rolling average of what it took to take care of that population? So if we can beat that, and we don't charge the insurance company against that, we'll keep some portion of the difference. You'll give us a rebate or you give us a bonus. And that's sort of the concept of an accountable care organization. Now, there's one-sided risk and two-sided risk. One-sided risk is that there's no downside risk, only upside. So the risk is actually on the payer. So if you deliver all the good care, but it costs less, you get a bonus. Two-sided risk is that you're really committed and you're saying, if we spend more money than we thought we would, we actually pay a penalty. And so UVA actually was in an accountable care organization up until about a year ago. It was one of the Medicare ACOs, and we were in a wave of academic medical centers and large health systems that did this, and it was a 3-year commitment. And at the end of 3 years, 2/3 of the models closed down. They said, this is not working for us. And we were one of those. We said, this is really not doing anything for us at all. And we decided not to renew. So these are models that I would say are in development, but none of them have really been perfect. This last line here, bundled payments for episodes of care, is another way to look at this. Any orthopedic surgeons here? We don't have okay. So bundled payments is sort of hot topic in orthopedics. But basically, this is that for an episode of care, like a joint replacement surgery, the insurer, in this case CMS, would say, this is how much we're going to pay from end to end, from the first encounter to the patient to the time that we're stopped paying for anything related to that surgery. And so what that did, and I think I have a slide on this, is that would take all of the different services, so lab, hospital, post-acute care, or nursing home or rehab things, and readmissions, and just bundle it together. So if you had the perfect execution of a surgical procedure, somebody gets a knee replacement and they're in the hospital, and post-op day 2, they get discharged. They don't need a nursing home. They have a couple visiting nurse things, don't get readmitted. The cost of that care is minimal. And so you're going to get a flat rate. So if your cost is minimal, you're going to have some positive margin on that. In the past, you got paid for each of those services individually. Actually, that's the present in most cases. So in fact, hospitals, and it's not just UVA, but hospitals actually historically make money off of complications, right? So we get paid when patients get readmitted. So, think about that, so bundled care is really, really flipping the axis on that. Yeah. Mm-hmm. Yeah, there's a concern about that. I think that that is fair to say. It does get back to the root cause of, the total cost of all the care and can society afford it? I think what's more likely is it would flatten. You just never get a raise, right? So if you look at, compensation for bundles, if you're the federal government, you're thinking long term, right? And so if you say, well, it's, $2017, it's $20,000, $30,000 for a knee, something like that. We'll just keep it there, forever. And that actually fixes the problem over many years. So that would be the concern, is that once you have that sort of price fixing, that it just never really changes. There's a lot of, back and forth, a lot of, argument that goes on about, how this would work. So in reality, I mean, it's a political issue. And you're aware probably that Tom Price, who was the Secretary of Health and Human Services, before he got removed for flying too many private jets, was an orthopedic surgeon, and he actually canceled all the comprehensive joint bundling programs. So we're actually just back in fee-for-service again. So it's interesting. Okay, I want to move forward a little bit because we probably only have a few minutes left. So what are we doing at UVA? Number one, over the last couple of years, we've really been focusing on trying to improve safety. And part of the strategy has been to improve the staffing models. So you see, a little bit more support for in-house attending supervision, things like the IRPA, the in-house surgical intensivists. We have, hospitalists in-house. It didn't used to be that way. Some of the faculty in the room can say, okay, when I started here roughly 20 years ago, and I would work a night shift in the ER, there were pretty much 3 attendings in the whole hospital. So there was the ER attending, the OB attending, and an anesthesia attending. And that was it, right? And lots of residents, okay? So now if you look, that number is much different. There is, there are hospitalists, there's the in-house rescue physicians, there's an in-house trauma doc, the PICU attendings are in-house, the NICU attendings, are in most of the time, and people are here later and later into the day. And so the idea of having experienced supervision has been one of the key efforts here. You'll also see that, at least during the daytime, there's a little more help than there was in the past in terms of things like other advanced practice providers, so nurse practitioners and things like that. So we're trying to make sure that the staffing is good on the professional side. On the nursing care side, we've really gone through an effort to increase the staffing levels of nurses. So 4 years ago, we were at a much lower relative percentile in terms of staffing than we are now. There's still some hot spots. There's still some areas where there's a lot of turnover and it's hard to catch up, but we've done much better. Other things are really trying to create different communication pathways. You could see, different things around handoff of care, huddles, interdisciplinary rounds, escalation of care policies, and trying to make sure people know what's going on. Believe it or not, and I'll say this to this room, your attendings actually do want to know when bad things happen to your patients in the middle of the night. They may be cranky and half asleep, when they answer the phone, but it's actually much better than coming in a couple hours later and finding out, oh man, my patient was getting sick and they ended up in unit, nobody told me, or even worse. And so call. It's okay. It's all right. So we talked about supervision standards. Many surgeons in the room probably were here where we went from so much concurrency to these now staggered cases where the attending physicians are in the room for the critical portions of procedures. So that's been a step in the right direction. Adding rescue resources, so we don't just have a code team anymore. We have a MET team, and we have all these other people you can call. There's like the adult, there's the PERT team and the BERT team and NERT team and all these other things. So, those are investments. I mean, we spend on all that stuff I just mentioned, in terms of in-house physicians and rescue teams and things like that, we spend about $8 million a year on that. So use it. We want you to use it. So I want to spend 3 minutes on patient flow. So yesterday, I think we started the day with 556 patients in the hospital. We technically have a 600-bed hospital, but functionally you always have a few blocked beds, and you can't run any system at 100%. So at 556, we were pretty much over capacity. We're at full saturation. So anybody here ever play like Chinese checkers? You know how that works, right? You can only move your piece if you can jump over another piece and go into an empty slot. So hospital bed management is a lot like Chinese checkers. And if you start with a board where all the slots are full, and even where some of them are glued to the wood, you can't play the game, all right? So what does that mean for our hospital? So what does not being able to play the game mean? Well, it means we have a certain number of people come into the system every day, all right? So we admit actually about 110 patients every day. So it's a pretty big fraction of the whole. About half of those come through the ED, and then another third-ish come through our procedural areas, and then there's some direct admissions and some other, and transfers. And so this is highly predictable. Okay, everybody thinks, oh, there's a bad day, there's a good day. It's like, no, it's pretty predictable. In fact, the ED volumes are actually more predictable than our scheduled volumes. Okay, yeah, so you caught that. That's something wrong with that, right? So variation in the system of like some days are busier than others is actually almost entirely self-induced. We do it to ourselves. So the OR schedule will be busy one day, and then it will not be that busy, or the cath lab will be really busy one day, and not busy another day. If you combine all those variations of, well, the OR is busy, and the cath lab was busy, and the interventional neuroradiology suite was busy, and the ERCP suite was busy, you'll have this spike, 90th percentile day, and the system's not designed to work around the 90th percentile. So you get inefficiencies. So we have all these dashboards and things like that, but here's what I wanted to kind of get at. So this is a system of queuing, okay? Everything in running, whatever, hospital, hotel, restaurant, it actually gets down to queuing of, people coming through the system, needing certain things, and then leaving the system, okay? And there are all these stops along the way. And so if you look at a queue, what this graph's really important. There's one thing you remember from this talk, it's about system saturation. And this is what they call a single server queue. So if you have, for example, somebody who does a simple-ish task, like they're a cashier, say cashier in the cafeteria, and you have a certain number of things that they need to do. So say a cashier, if they're working hard, they can take care of 60 people per hour, okay, in their maximal state, okay? So if you get to, or in a reasonable state. So at quarter of that capacity, you say 15 people an hour, boy, it takes no time at all for them to do that. They're under capacity, they're very efficient, they can do everything that they need to do. When you start getting up into 60% of that capacity, so 30 people an hour going through that cashier, it takes a little bit longer because there's variation. Everybody needs something a little different. There's a certain error rate, and things start to get a little harder. It takes a little bit longer to complete each task. So basically, every system, when you exceed about 85% of capacity, inefficiency rises exponentially. Okay, so if you think about your own work, there are a few inpatient docs here. Okay, if you have a service size of 8 patients on a day and a couple of cases to do, probably works okay. What happens if you have 12 patients, 15 patients? All of a sudden, balls start getting dropped, right? And so all the bad things start happening. So you have delays, right? You can't be in too many places at the same time. You have competition for resources in the environment. So in the case of bed saturation, people start overflowing into areas that they don't normally go to. So, one of the big things that I hear about all the time is, oh, we have so many boarders, from, the medicine patients are up on my floor or things like that. And it's like, well, it's competition for resources. It's because of the high saturation. But all the bad things start happening, increased error rates, or decreased patient satisfaction. So when we try to model around things, we really try not to model at that 100% level because it's impossible. But as systems grow, it's sometimes hard to keep up with the different resources. We have, as I said, a lot of different dashboards. We track these things every day. The two lower panels there are actually sort of interesting, and I want to bring that up to you guys. So this is a heat map where the darker colors are low activity, the orangish colors are high activity. And so this is your admissions by day of week and hour of day. And you can see our average admissions, start picking up around 2 or 3 o'clock and, kind of go until about 9 o'clock on most weekdays. In terms of discharges, we try and get people out a little bit earlier, but you can see that our average discharge time is probably around 2 to 3 o'clock in the afternoon. That's when the people actually leave the hospital. So this is a problem. You've got about on this slide, for that 30-day period, it was 107 patients in and 106 people out every day. So the problem is if those two occurrences happen too close together, you basically have competition for the same inpatient space by both the patient who's coming in and the patient who's still there who is planning to leave. And that's where you get into OR holds, PACU holds, ED boarding, people who call from the outside and can't be directly admitted because there are no beds. So there is actually a solution to this, which is if you move this towards this time of day, there's actually plenty of time to get those people out and get the new people in. So actually, when you look at the midnight census works. We don't have all these boarding issues on a daily basis everywhere else, but you have significant process delays throughout the day because of that. Anyway, it looks like we're losing people. We're out of time, so I just wanted to stop there for any questions. It doesn't have to be about flow, it can be about other things. All right, well, thanks.